Good morning, sir.
Yeah,
good morning, everybody.
Yeah, good morning. So,
Good morning, sir.
Good morning.
Good morning. So today we will have a discussion on ward-round scenario of acute, maybe main discussion will be small bowel obstruction, but it's a bowel obstruction. I request Dr. Shomen Shah will be presenting. He's a third-year junior resident at RKM Shriapradistan, National Institute of Medical Sciences. Dr. Partho Sarathi Ghosh, who is Associate Professor of Surgery at Diamond Harbour Medical College, will take us through the scenario. Okay, so Shomen, you can share the screen for the scenario. Yeah, Shomen, you can read this scenario, please.
Yes, sir. A 50-year-old female attended the ER with complaints of pain abdomen, vomiting, and absolute constipation since 1 day. On examination, BP is 96/62 mm of mercury. Pulse rate is 118 per minute. Per abdomen findings are distension. Abdomen is distended, flanks are full. So, how will you proceed with this patient?
So, what is your initial diagnosis? Impression, I think.
Sir, a 50-year-old female attended the ER. So she came with first pain abdomen, and the location of the pain is not mentioned, and it was associated with vomiting and absolute constipation. So it may be a case of intestinal obstruction.
What, chronic or acute?
Sir, as the history is for 1 day, so it is a acute intestinal obstruction.
Yes.
So if you are experiencing an acute intestinal obstruction in this case, what should be the nature of the abdominal pain?
Sir, abdominal pain will be colicky pain, sir, and it will be intermittent, sir. And
obviously, colicky pain will be intermittent. Anything else? What will be the location of the pain?
If it is small intestinal obstruction, sir, the pain will be central in location.
Okay, and in case of large bowel?
In case of large bowel, sir, it may be in the either in the right or left flank according to the location.
It's more in the lower abdomen, actually, right?
Yes, sir.
Any
yes,
other difference between the large bowel and the small bowel colic in case of intestinal obstruction?
Sir, in small bowel obstruction, vomitus presence
In pain.
earlier.
Pain.
Okay, sir.
Regarding the periodicity of the pain? Pain
Sir,
in case
on,
of small, yes.
On taking meals, sir, the pain aggravates, sir.
In case of small bowel, it comes with the periodicity is actually short. It comes in 3 to 4 minutes. But in case of distal the obstruction, you will get a pain-free interval of 15 to 20 minutes in between. So more distal the obstruction, the cramp comes actually a bit late. In case of colonic obstruction, distal small bowel or colonic, whatever. Any other? Do you expect any change in this pain as the obstruction advances?
Sir, if the pain becomes continuous, sir, so it refers towards strangulation.
Yes.
Yes. Right. Severe, I mean a constant, severe, non-crampy pain points towards the diagnosis of strangulation. And if it occurs, I mean if it is a partial obstruction and develops over time, gradually the pain disappears.
Yes,
even in presence of obstruction because of the fatigue of the bowel, isn't it?
Okay, sir.
Yes. Now, what distension? How distension suggests us about the location of the obstruction or the nature of the obstruction?
Sir, in small bowel obstruction, there will be distension in the central part of the abdomen.
Okay.
And in the large bowel obstruction, we can, according to the site, we can get the site of distension. For example, in sigmoid volvulus, and later on it will become a diffuse swelling. In earlier stage, we can differentiate, sir.
In case of small bowel obstruction, more distal the obstruction, more the distension.
More
In
the
case of
distance.
colonic, yes, in case of colonic obstruction, the distension develops later, and it all depends upon the nature of the idiosical bulb or the functioning of the idiosical bulb.
Okay, sir.
What about constipation or obstipation? How it
Sir.
can guide you in the diagnosis?
Sir, if there is small intestinal obstruction, sir, in first few hours, the patient may pass feces or flatus because of stored stool. But later on, the patient will go into obstipation. That means he won't pass in neither stool or nor stool, stool or flatus. So he will develop obstipation.
Okay. So if it is a progressive obstruction or a complete obstruction, actually there will be gradually the patient will develop obstipation, and if there is the bowel, I mean the stool and the gas that is present in the distal colon, will gradually disappear. So you have to, the thing is that you have to examine the patient serially. Otherwise, you cannot understand what it is.
And Somen,
Yes, sir. Yes,
it's
sir.
not only small bowel. The concept you are talking of is when the patient has got obstruction, the stool remaining in the distal to the obstruction may pass off. So this can
Yes,
happen
sir.
in large gut also.
Yes, sir.
If you
Yes,
get
sir.
transverse colonic growth, the distal part may also pass. So it will not specifically decide about small or large bowel obstruction. Okay, this can happen at the beginning. What about vomiting? You said vomiting. What about vomiting? What history in the vomiting is important?
Sir, if it is bile stain or not, sir, first of all, and in case of small bowel obstruction, the patient will present with vomiting earlier, and in large bowel obstruction, their vomiting will be late presentation, and it may be feculent, sir.
Okay.
Yes, so in case of small bowel obstruction or any obstruction distal to actually gastric outlet, and better we get a bilious vomiting. Now feculent vomiting or is actually, there are two reasons. If the obstruction is progressive, with development of time, there is bacterial overgrowth. So actually, the nature of the vomiting changes. So if a bilious vomiting becomes a feculent vomiting later on, then it indicates the progression of the the obstruction from a partial to a complete. Whether constipation is mandatory for diagnosis of intestinal obstruction, or even in some cases the patient may present with diarrhea.
Obstruction, but patient has diarrhea. What is the situation?
Sir, if there is a infectious focus in the pelvic inflammatory disease, it will irritate the colon, distal colon, and patient
So
may pass mucus.
Obstruction with a pelvic abscess. That is something.
Yes, sir.
Anything else? Any hernia
Sir,
where the periphery of the bowel is trapped causing obstruction, but the lumen is open to produce diarrhea.
There is a Richter's hernia, sir.
Okay. Gallstonitis. Here you can also get.
Yes, sir, also.
And even you always remember, any case of partial obstruction because of the hypermotility of the gut, you may get diarrheal episodes. So constipation,
yes,
most of the patient presents with constipation, but it's not mandatory to present with it. Now, now when you are assessing the cause of obstruction, what other histories you must keep in your mind in history taking or evaluating the patient? You must keep in your mind some specific history in case of intestinal obstruction.
Sir, history of sir any
that is the question that is asked is to take a history to come to the cause of obstruction, because you have an idea that patient has got obstruction. Now, the next part of the history is important to have an idea whether you can make out any cause of obstruction, because there are some defined causes of obstruction. So tell us the details about the history which might help you to come to a diagnosis, more precise diagnosis.
Sir, I will ask the patient about any history of any previous abdominal surgery, sir.
Very good.
Any history of tuberculosis
Okay.
and Crohn's disease, sir. And if she is having any diabetes mellitus or any hypothyroidism.
Try to address the causes of obstruction. The first thing you started is operative history,
Surgery.
because
Yes,
adhesion is
addition,
cause
most
obstruction.
common.
Second cause of obstruction is either a neoplastic or hernia. So you have
Yes.
to ask the patient whether the patient has got any swelling in the
Swelling.
defined sites of hernia. Okay, patient may
Yes,
miss,
sir.
but some patient may give you a diagnosis, a history of the hernia. Next is neoplastic. This is
Any
elderly,
swelling in the
58 years lady. So how do you make out neoplastic pathology in this patient in the history? Patient come with acute episode of one day. What in history is important to diagnose that this patient might have some underlying neoplastic pathology?
I will ask, sir, about any mass in the abdomen and history of weight loss, sir. Weight loss, anorexia before the event.
Yes.
It will there may be altered blood, presence of altered blood in the stool. These histories point towards neoplastic pathology.
So you should ask history to find out whether it is just an acute obstruction or is a acute and chronic obstruction. So patient having a acute and chronic obstruction, there's some history like this. Patient may have earlier history of pain abdomen, which was dull aching, may mild distension and pulsed with stool, disappear distension. So this history is important. Whether this patient has got similar episodes of subacute obstruction in the earlier period. Okay, because
Yes,
neoplastic obstruction does not come on with a sudden acute obstruction. Patient may have some symptoms earlier.
And one more important thing, you must ask for any previous episodes of bowel obstruction and any evaluation that has been undertaken because of that. If she has history of such intestinal obstruction in the past and the radiological evaluation plates are available, you must have rechecked them. This is very important for assessment. So this is one, any previous history of bowel obstruction, previous abdominal or pelvic surgery, neoplastic feature suggestive of any neoplasia or feature suggestive of any intra-abdominal inflammatory pathology like inflammatory bowel disease, pelvic inflammatory disease like this. And of course, any setting that you were telling about, any medical settings which can give rise to IBS or any intestinal obstruction like features. And another important thing you never forget, that whether the patient is in immediate post-operative, that is actually a different entity how we deal with those patients. Immediate post-operative obstruction.
Yeah.
yes, sir.
Right now. Now, in a way, in very short, how we go for physical examination in case of abdominal examination, in case of intestinal obstruction, what do we expect?
On inspection, sir, I will look for any distension of the first. I will look for any distension of the abdomen. Or I will check, inspect all the hernial sites,
Very
and
good.
I will look for any visible peristalsis, sir.
Right.
What in peristalsis is important? You have discussed about the pain. So looking at the abdomen, how can you make out the peristalsis arising from that particular segment of the gut? What are the characteristics of visible peristalsis in obstruction?
Sir, in obstruction, the gut segment will try to overcome the obstruction by vigorous peristalsis.
Is it small gut peristalsis, large gut, or gastric peristalsis because of some gastric obstruction?
So in small gut, in small gut obstruction, sir, the visible peristalsis will be in the central part of the abdomen,
Number one.
and in large gut, sir, it will be in the periphery.
What else?
Small gut is not yet finished.
One is central abdominal peristaltic webs. What else? It will be like
Step ladder.
these
Step
are
ladder, sir.
step ladder, and usually these are
Yes, sir.
small peristaltic webs coming in a step
Comes
ladder.
and goes.
Okay,
Yes,
and
sir.
large gut peristaltic depend on the site of obstruction, really more peripheral.
Yes, sir.
Okay,
Yes, sir.
fine. Then
And you must always look for a mass, whether it is present. And the most important finding in case of inspection, you must look for an abdominal scar. That is very important,
Okay, sir.
right? Now,
Yes,
in
sir.
auscultation,
In auscultation, sir, I will auscultate for the intestinal peristaltic sound, sir. It may be in mechanical obstruction, it may be hyperperistaltic at the beginning, proximal to the obstruction, and later on the abdomen may become silent. And in
a silent abdomen in the background of acute intestinal obstruction means what? Whether it is, it means that the obstruction has resolved, or it still persists.
Sir, in paralytic ileus, sir, abdomen may be
No,
silent,
in
sir.
case of mechanical bowel.
Okay, sir.
it was hyperperistaltic. Now, after 1 hour, you find the abdomen is having a less and maybe silent abdomen. So, what might have happened?
Sir,
If the bowel,
first possibility is
yes,
the obstruction has resolved somehow.
yes,
And another possibility is, sir, due to strangulation, sir.
yes. So, when there is
The bowels.
strangulation sets in, the peristaltic web may go up.
Yes, sir.
So you have to keep in mind.
Yes,
Yes. Now, in palpation, what important finding you should wait for?
Sir, in palpation, sir, I will look for any mass, palpable mass, sir.
Yes,
And
one thing.
Yes. Is abdomen
all
tender?
the
Yes,
Is
the
abdomen
gagging and-
tender in
and
patient
tender.
with acute bowel obstruction?
No, sir. In case of strangulation, it becomes diffusely tender.
Even in obstruction, patient may have some tenderness because
Even
of
in-
that distension. Okay, but specifically in strangulation, you will have what?
Tenderness, sir.
Rebound
the-
tenderness.
Rebound tenderness.
Rebound tenderness. Yes.
The tenderness more at the site of strangulation. It may develop general peritonitis, generalized peritonitis. Then you get acute tenderness along with guarding and rebound tenderness. That is very important. So you want to go for a digital rectal examination?
Yes, sir. In acute in intestinal obstruction, sir, at first the on digital rectal evaluation there will be rectal ballooning first, and there will be, and later on the rectum will be collapsed, and finger may be stained with mucus and mucus or blood.
Then what do you think? If the finger is stained with mucus and blood?
Sir, mucus may be present, sir, normally. Presence of blood may be, if it is fresh blood, there may be any local cause, or if there is altered blood, sir, neoplasia may be present, sir.
Now,
In an elderly lady, you're finding mucus, you cannot pass it as normal.
yes, it should not be normal.
Yeah, 58 years lady, if you have a mucus and blood in the finger stall, it should not be passed as normal. Okay, mucus may be a situation of some conditions where you may have increased mucus in stool also.
Okay, sir.
And rectal examination, you may have, if it's a neoplastic situation, you may find other mass in the pelvis, maybe a Bloomer shelf. Okay, because
Yes, sir.
a neoplastic lesion causing obstruction means it should be considered as advanced disease.
Yes, sir.
Now, you have received the patient in the emergency, this patient. What will
Yes,
be
sir.
your next step after this assessment?
Sir, first I will, after diagnosing, I have diagnosed I will diagnose the condition by doing an X-ray supine position, and I will,
This patient is in
and in the
shock or
meantime,
not? This patient in shock or not?
yes, sir.
She is in
BP
shock.
is,
Yes.
yes, sir,
So
and
you cannot send
tachycardia,
the
sir.
patient to radiology straight away. So resuscitation and evaluation will continue simultaneously.
Yes, sir.
Okay.
When you
Sir,
were
yes,
diagnosing this patient as an case of intestinal obstruction, the patient remains in shock. You have to resuscitate. You start resuscitation. You have to ask for an admission. You have to admit this case. Admission
yes, sir.
in case of suspected intestinal obstruction means many things. So always keep in mind, until and unless you are very sure that the patient is not having, even if the patient is having a partial bowel obstruction, it is always judicious to admit the patient to assess the progress of the obstruction.
Yes, sir.
Now, how you want to resuscitate the patient?
Sir, I will resuscitate the patient with IV fluids, normal saline and Ringer's lactate, sir, and I will place a Riles tube to decompress the stomach, and I will do catheter, pulmonary catheter to measure the urine output. And if there is strangulation, signs of strangulation, sir, after resuscitation, I will take the patient for operation.
Wait. Don't jump. Don't. You say resuscitation with Ringer lactate. What is the solution? Ringer lactate. What does it contain?
Sir, lactate, sir, and
Lactate.
potassium.
So you should always keep in mind the underlying electrolyte status of the patient to decide about the fluid management. Okay.
Okay,
So
sir.
this patient who is vomiting, what are the usual changes in the patient metabolic status?
Sir, hypochloremic, hypokalemic.
First is dehydration, number one.
Yes, sir. Yes, sir.
Next is
hypochloremic, hypokalemic, metabolic alkalosis.
hyponatremic also. Hyponatremic, metabolic,
Also.
metabolic alkalosis.
Yes, sir.
This will happen if you have more predominant vomiting. If you have distal bowel obstruction, what is going to happen? Patient has sequestration of fluid in the small gut.
Yes, sir.
So what is going to happen? If you have fluid sequestration in the small gut, you see there will be a distended loop of gut.
Yes, sir.
So fluid sequestration in the small gut results in what? What biochemical abnormality? What is the small gut content? Acid or alkali?
Sir, alkali, sir.
Alkali. So if there is
Yes, sir.
secretion of fluid in a small gut, there will be again hyponatremia and metabolic acidosis.
Acidosis, sir.
So whether the patient will be in acidosis or alkalosis will depend on what? Will depend on the amount of vomiting and amount of sequestration.
Yes, sir.
So if you have not tested for the metabolic status, it is not wise to start with Ringer lactate solution if the patient has more predominant vomiting. Why? If the patient has more predominant vomiting, I would not start with Ringer lactate solution. Why?
Sir, if there is the patient is in acidosis, sir, it will.
I said more of vomiting. More of vomiting means status is patient will be in alkalosis.
What will happen to the lactate? How lactate is metabolized?
You got my point. If the patient is
Yes, sir.
vomiting more, patient is in the state of metabolic alkalosis. Okay.
Yes, sir.
If we give
Yes, sir.
ringal lactate, the alkalosis get aggravated. So if you have the facility to test for this metabolic status, you plan accordingly. Otherwise, you can start the patient on normal saline because patient is vomiting more predominant vomiting. Patient has more predominant vomiting. So in that case, think about the fluid you're going to start. Okay. So how much
Okay, sir.
fluid will start at the beginning?
Sir,
Patient,
that will.
patient is in shock. 96/62 is a BP.
118
Sir,
pulse.
sir, I will give, sir, bolus of normal saline 1 liter,
Yes.
and over 30 minutes, sir.
Fine. So give a fluid challenge of 1 liter. Fine.
Yes, sir.
So you have given the patient fluid. When will you understand, yes, the patient is adequately hydrated?
Sir, I will check for the urine output, sir. Urine output, sir. Sir, urine output, blood pressure and pulse will improve, sir, if the patient becomes adequately hydrated, sir.
Got disconnected.
Hello. Yes, yes. Not of course you are
Sir.
audible.
Then, sir, we should proceed now.
Yes, yes, yes.
Now you, how you want to investigate this case? You were trying to tell that.
Sir, first I will do an X-ray of to look for obstruction, and it will also.
What X-ray would you suggest?
The straight X-ray abdomen with in supine position, sir. AP view.
Fine. Why you want to take the film in supine position?
Sir, supine position, I can appreciate the distended bowel loops, and by the character of the bowel loop, I can come to conclusion which part is obstructed, and I will also look for absence of colonic gas shadow in case of proximal obstruction, sir.
Okay, fine. If you take the X-ray in erect posture, what will happen? But what changes you expect?
In erect posture X-ray, I can see the air fluid level in stapler pattern. There will be multiple air fluid levels, sir.
So air fluid levels are more well seen in erect, X-ray taken in erect posture. But number of air fluid levels doesn't mean anything actually until and unless the obstruction is very advanced, where the number of air fluid levels actually corroborate with the progress of the advancement of obstruction. Otherwise, number of air fluid level actually doesn't indicate anything, isn't it? So it is always the X-ray should be taken in supine position first. Right.
Yes, sir.
Now, how can you differentiate between a large bowel obstruction and a small bowel obstruction in a radio? In X-ray film?
Sir, in large bowel obstruction, sir, colon will be dilated more, and I can identify it by looking at house station, and the dilated segment will be more in the periphery.
Okay.
And in the small bowel obstruction, if ileum is obstructed, then ileum will be distended, and the ileum is featureless on X-ray. And in jejunum, there will be presence of
Presence of valvuli
conniventis.
How to differentiate between hospitations and valvuli conniventis?
Sir, house stations, it is incomplete mucosal bulging, sir, and it is alternate in
Yes.
position, and
They
valvulic
characteristically
convent is there
interdigitated.
interdigitating, and in valvulic convent is those are complete rings, sir.
Okay, fine. Now, can you pick up cases of strangulation in case of from an X-ray?
In case of strangulation, sir, if there is peritonitis, sir, there will be ground glass opacity.
Nothing.
Otherwise, sir, X-ray is not very helpful.
If you also get free air, peritoneal air, if you get pneumatosis cystitis, so these are sometimes you may get which suggests a strangulation. And one very important thing here, if you are following a patient, if you can take an X-ray in supine position and one X-ray in direct posture, and you get a fixed bowel loop in a fixed part of the abdomen, that means probably you were dealing with a fixed obstruction. So presence of same bowel loop in both posture indicates something. In case of can you get how will you identify a gallstone ileus in case of from an X-ray?
Sir, in gallstone ileus, sir, there will be air in the biliary tree, sir. I will get pneumobilia
Pneumobilia.
and
What is
and
Ziegler strat?
sir,
What is
it is a
Ziegler
tract.
strat.
Yes, sir. It is seen in gallstone ileus, sir.
What?
It
One is
comprises
gas
of
in the biliary tree. What else?
gas in the biliary tree, acute intestinal obstruction, and another is radioepic shadow in the abdomen.
Very good.
Very good. So you must look for this, especially the lady who is aged. Gallstone ileus almost always happen in case of aged patients, specifically above the age of 60-65 years. So if you get such a patient, they always think of whether you were missing any gallstone ileus, and especially recurrent obstruction, which is partial obstruction in these cases.
Yes, sir.
Now, sir.
Chomen, while assessing the patient in emergency and continuing resuscitation, it is important to clinically diagnose the patient having strangulation obstruction or non-strangulation obstruction, because the management will vary. So what are
Yes,
the
sir.
important features of strangulation obstruction? If you start with the history, then examination, and some investigation, how do you diagnose strangulation obstruction?
Sir, in strangulation obstruction, sir, the history, the complaints will be of long duration, sir, longer duration, because it takes time strangulation to develop, and
Strangulation can occur within 6 hours. It's not required that patient have strangulation obstruction for 2-3 days. Okay, if you have an acute volvulus, the strangulation
Yes,
can
sir.
come very fast. So time is not important. What else is
What
important?
are the signs? Number one, the nature of the pain either
Yes,
has changed
you
or
already said.
already have said.
The colicky pain will be changed to constant, continuous
continuous pain,
pain.
sir.
Then
Anything else?
patient will have some features of toxemia, like
And patient will, like, sir, fever, sir,
yes,
Yes.
fever, and features of shock like hypotension and
yes,
tachycardia,
Yes.
Then
mm,
what else?
and rebound tenderness, sir.
Very good. The
Rebound
peritoneal
tenderness.
signs.
And
Yes.
In
I
blood
will
investigation?
in
And
sir, sorry, sir.
basic and some basic investigation will point towards the diagnosis.
What will happen to the leukocyte count?
Sir, there will be leukocytosis, sir, increased TLC.
And
Yes. And anything else? Like serum lactate?
So lactate will be increased, sir.
Yes. Blood lactate may be increased. And
Yes, sir. And patient may be, sir, in acidosis, sir. If we do ABG.
most of the patient with distal small bowel obstruction may have metabolic acidosis because of small bowel fluid sequestration. Yes. Okay, so this is important to differentiate a strangulation obstruction from simple obstruction because the management will vary. What is the difference? A strangulation obstruction management
Yes.
and
Sir, in
non
strangulation.
Why
inst-
we do want to pick up the cases of strangulated obstruction very early and separate? What is the reason? Why we are so much interested with the strangulated cases?
In strangulation, the gut loop may become gangrenous if we don't operate early.
Actually, the problem happens in the outcome. In simple obstruction, the mortality rate is around 5%. But in strangulated obstruction, the mortality rate goes up to 30%. So if you cannot pick up the cases early, you are going to lose patients. And the difference is huge. That's why we want to pick up the strangulated cases in the very early.
Yes, sir. Sir, in strangulation, if I suspect strangulation, sir, I will take the patient for exploratory laparotomy, and if there is simple obstruction, sir, I can proceed with medical management.
Okay, then how can you differentiate between these two? These are clinical features, of course, this suggests. But whether, suppose you are dealing with the lady that you are dealing with in the emergency is having a large bowel obstruction from the from the sciatum. Now you are not sure whether you are dealing with a complete obstruction or an incomplete obstruction or the nature of obstruction. Do you want to take help of any adjuvant, any investigations, any adjunctive tests? It's a large bowel obstruction. You are working in one of the best facilities, but you are not sure whether you are dealing about the nature of the obstruction.
Sir, then I can go for CT scan or contrast enhanced CT scan of the abdomen, sir.
Anything else? In case of, I am specifically mentioning it's a case of large bowel obstruction where for more specifically, the air has come up almost up to the sigmoid colon. There is presence of air in the lower part of the large bowel. Actually, if there is any uncertainty regarding the presence type or level of colonic obstruction, you should go for a sigmoidoscopy first if it is available. And if it shows a complete obstruction, then something. Otherwise, if you are not definite with if you don't get anything in the sigmoidoscopy, then you go for a contrast enema. In case of large bowel obstruction, it will differentiate between a mechanical and a non-mechanical obstruction, as well as you will get some views regarding complete and partial obstruction. But if you are dealing with a small bowel obstruction, then either you can take help of, better to take help of a CT scan where the diagnosis is in doubt. What are the criteria in CT scan by which you can diagnose intestinal obstruction, small bowel obstruction?
Sir, the diameter of the distended bowel loop, sir. For small bowel, it is 3 centimeter. For colon, it is 6 centimeter, and for cecum, it is 9 centimeters, sir.
Right.
For small bowel, 6 centimeter.
No, sir, 3.
3. Good.
Yes, sir.
And 9 centimeter cecum is critical dilatation.
Yes, sir. Yes, sir.
Anything else?
And I can also see the cause of the obstruction.
Very good.
I can see any
inflammatory pathology, neoplastic pathology.
It is intraluminal or wall or in the wall or extraluminal, sir.
Done. Either it's an inflammatory pathology or neoplastic pathology, you can identify, or a band, whatever that you can identify. Anything else?
Yes, sir.
Whether there is any discrete transition zone or not, isn't it? From a dilated
Yes, sir.
bowel to a collapsed bowel.
You can find the transition zone also.
Transition zone. Yes, sir.
Okay. Whether you are dealing with a closed loop obstruction or not. The presence of a closed loop, how it looks like in a CT scan.
Sir, it will be a distended segment of bowel, and
Yes.
proximal and distal to it, there will be constriction, sir.
No. It's a closed loop. I am telling now it's a closed loop. It is obstructed by at its two ends. So it's a
Yes, sir.
C-shaped or a U-shaped dilated bowel loop associated with radial distribution of mesenteric vessels converging towards a torsion point. Am I right?
Yes,
So
sir.
you will be
Yes, sir.
able to see like that, like a fan.
Yes, sir.
Now
Any-
what are
Yeah.
What
Any
are the-
features of strangulation in?
yes? What are the independent predictors of strangulation or ischemia on CT scan? This is very, very important. Why you go for us? What are the points?
There are some features which suggest strangulation, like
Like, sir, presence of air in the wall of the
yes, pneumatosis.
pneumatosis
Intestinal.
intestinal.
Good. What else?
And, there will be free fluid in the peritoneum. Ascites may be present.
What is the amount of free fluid? Any amount of free fluid is not an independent predictor of ischemia. What is the amount of fluid in CT, on CT? It should be more than 500 ml. Then it specifically points towards the strangulation.
And anything else in the portal vascular system?
Other than blood,
Air.
Yes, sir.
Yeah. Air in the portal system indicates that might be some strangulation.
Strangulated.
Yeah.
Yes, sir.
what about the mesentery? Mesentery must be edematous. Absence of edema of mesentery actually almost excludes the diagnosis of a strangulated obstruction in case of CT. What do you mean by a small bowel feces sign?
So it's a small bowel.
Feces sign. Whenever an obstruction develops very gradually, feces we generally get, we do have an impression, or we have seen feces inside the colon. Sometimes such an impression, such a material, a mosaic type of pattern, we may get inside the small bowel lobe. That is feces in small bowel. But it indicates that the obstruction has developed gradually to allow absorption of the fluid from that part of the small bowel proximal to the obstruction. So if it is absent, then the strangulation is more suggestive. Am I
Okay,
clear?
sir. Yes, sir.
What is Wald sign or Waldpool sign?
Sir, it is the finding in CT scan
Yes.
seen in sir volvulus, sir.
Yes.
The wild arrangement of the mesenteric vessels. It is
Yes,
seen in
around. So the arrangement of the bowel or
yes.
the mesentery around these vessels. So it's an abnormal swelling force of the mesenteric vessel. And at last is the reduced bowel wall enhancement. That is also important, and you must look for that strangulated bowel should have less enhancement on CT scan. So these are the things that we look for.
What is target sign?
The target sign, it is a sign of intussusception, sir.
Yes.
Due to telescoping of one bowel segment into
How it
into
appears in
another.
CT scan? How it appears in CT scan?
Sir, it appears in CT scan as concentric rings.
So it appears bowel within bowel.
Bowel within bowel, sir.
Okay, these are all specific
Yes, sir.
diagnosis of underlying conditions.
Yes, sir.
With all these things, now we have to decide. That is very important. Who are the candidates to be taken for an emergency surgery? Who are the candidates where an urgent surgery is required. That means we can resuscitate the patient well, we can observe for sample and then take to the OT. And who are the candidates where we can allow expected treatment? The patient has a very high chance of improvement on non-operative management. So these are, so you have to categorize the patients on the basis of clinical examination, history taking, and radiological and and laboratory results that you have received, isn't it? So
Yes,
who
sir.
are the patient? Who are the candidates to be taken for emergent surgery?
You have discussed some
Sir,
part.
You have discussed. You have to collect them and say properly.
Indication for early surgery immediately after resuscitation.
sir,
Actually, you have to decide the patient that yes, this patient requires surgery. You are go on continuing resuscitation. Sometimes resuscitation even may be difficult in presence of strangulation, and you have to take the patient off as well.
sir, obstructed hernia, sir, and
First is strangulation obstruction.
gallstone
One part.
ileus.
Strangulation obstruction is a prime group.
Yes, sir.
We were picking
That
up the
patient
cases
is-
of strangulation.
Then,
Obstructed,
you are
sir,
right.
obstructed hernia, sir,
Yes, yes.
gallstone ileus, and if obstruction is due to any neoplasm, that we can do emergency surgery.
Hmm.
And sir, also, sir, intussusception and volvulus.
Yes. Suppose
Also-
if we discuss a little bit of, suppose this elderly lady has got a sigmoid volvulus. You have diagnosed
Yes, sir.
the history and
You will
the
take the patient to OT.
what are the options? What are the options for treatment for sigmoid volvulus? What is important at the beginning to differentiate is strangulation and non-strangulation. Strangulation means upfront surgery. If it is a non-strangulating volvulus, what are the options
sir.
for treatment? Non-strangulating
Sir,
volvulus of large gut.
Sir, I can pass a flatus tube parectally.
Than that, now it is not
endoscopy.
advisable to pass a blind flatus tube because we have now more better facilities. Yes,
Sir, endoscopic derotation, sir,
yes,
may be attempted.
yes, gentle. So that you have to be keep in mind that I've already said non-strangulating volvulus. If there is suspicion of strangulation, one should not attempt for this endoscopic decompression. Suppose
Yes,
you have successful in endoscopic decompression. What is next treatment? Discharge the patient tomorrow morning?
No, sir. The patient must be planned for exploratory laparotomy.
For what?
When?
And when? Why you want to explore the patient? Because the problem is solved.
No, sir, the patient may complain of recurrent volvulus
Yes,
again.
the chance of recurrence
Because
is very high.
Yes.
So you have
is
to,
very high.
So
you have to, what
Explore.
operation you will offer?
So you have to optimize the patient. The idea is the emergency is over. So in the same admission,
sir.
you optimize the patient and take up for surgery.
Take up
And
as an
what surgery
elective
do?
case
It
in the
is
same
required.
hospital admission.
Okay, sir.
So remember, in case of sigmoid volvulus, where there is systemic toxicity or peritoneal signs, you have to take the patient for emergent surgery. But if it is not so, you go for a sigmoidoscopic derotation. If it is successful, then you can take the patient for an elective operation in the same admission. But
Admission.
there are other kinds of volvulus, even a small bowel volvulus, a cecal volvulus, or a transverse colon volvulus, very rare. But these volvulus, there is no role of any observation or non-operative treatment. So any volvulus proximal to the sigmoid should be taken for emergency surgery. So any strangulated obstruction or any obstruction, including hernia, the peritonitis, hemodynamic instability, laboratory signs of ischemia or X-ray sign. So these, the closed loop obstruction, the sigmoid volvulus with toxicity, and any volvulus proximal to the small bowel to be taken for emergency surgery. Right. In other cases, we generally go for an expected treatment. Now, how to follow up a case when you have selected the case for a non-operative management?
Sir, I will look for our investigations if there is any cause of paralytic ileus, and if it is absent, then
you don't forget the clinical monitoring. Don't forget the clinical monitoring. Patient is admitted. You have decided for conservative.
You have to monitor the patient continuously, at least every 4 hours, 3 to 4 hours, and it is always justified that the patient must be clinically evaluated by the same surgeon or same group of people for a good to look for a good progress or deterioration of the patient. We have to only look for whether there is the bowel obstruction is progressive or not. How will you say that the obstruction is progressive?
So there will be increased distension, and the pain will be more, sir.
And yes, increasing in abdominal pain, distension, tenderness, the nasogastric acid changing from non-feculent, proximal bowel. If you take another X-ray after 4 hours, you may see the disappearance of the distal gas. So these are the signs where the bowel obstruction is progressive. Right?
Yes, sir. Yes, sir.
Now, suppose let us discuss this little time. Now, suppose in early post-operative period, let us discuss what the specific scenarios. Suppose in a very early post-operative patient period, the patient is having features of intestinal obstruction. How would you proceed or deal with this? This happens in our day-to-day practice.
Sir, I will keep the patient on IV fluids.
Yeah, what are the cause? The first thing of cause. A patient done a laparotomy, and you have done a gut resection, and now patient is having post-op distension, obstruction. The important causes are what?
Sir, due to effect of general anesthesia, sir, and overdose of narcotic drugs, sir, and also electrolyte abnormalities.
These are all non-mechanical obstruction you are talking of. Mechanical obstruction?
Most common cause.
Sir, immediately after operation, sir.
Not after immediately, not within 24 hours. Maybe within, within the hospital stay. That means within, suppose after 3 days, 4 days, 5 days, 6 days, 7 days, like this. Within the hospital, so the patient develops intestinal obstruction. It may happen you are planning a discharge of the patient, but the patient develops intestinal obstruction.
These are mostly because of adhesion. Okay.
Yes, sir. Yes, sir.
Most of the cases, more than 90% of the cases are because of the adhesion. Right? How to manage this? How these adhesions behave? They are actually different from, these are fibrinous adhesions, and they are different from the fibrous adhesions, which the patient may later generally present in the latter part of following operation, 1 month to 20 years, whatever. But these adhesions are different and they behave differently. So what you expect, whether they are going to resolve or you want to reoperate?
Yes, sir. I will continue, sir, conservative management, sir. And I expect them to resolve.
How long? So actually,
Of course.
actually most of the patient resolves within 85 to 90% of the patients actually resolve within 2 weeks. But of course, many of them resolve in the first week also. So jolly well, you can wait for 1-2 weeks in these cases. You can put the patient on TP and whatever. But the traditional indications for re-exploration are in these cases are actually deteriorating clinical signs, worsening of the obstructive symptoms, and failure to respond to non-operative management after 2 weeks. But staying hospital the first after 2 weeks, it may be reasonable in some cases, or you can reassess after 7 days. But for first 7 days, if there are no deterioration of the clinical status and the obstructive symptoms, it is better to go for conservative management, because most of the cases actually resolve spontaneously. And one more thing,
Yeah.
why we go for observation, the chance of strangulation, what has been seen in case of post-operative adhesive obstruction, is extremely low, probably less than 1%. So that is the statistics which help us taking this decision in these cases. Yes, sir.
Another important concern in this situation is most of them will resolve. You explore if there is features of strangulation. Second is this fibrinous adhesion after 2 weeks become more vascular. So if you are trying to explore after 2 weeks, you should be very cautious. You may end up
Yes,
with a
sir.
lot of enterotomies. So if the patient is relieved within 2 weeks, fine. If not within 2 weeks, again, there is a role for continuing conservative treatment in the form of nasogastric tube placement, parenteral nutrition. Because after 2 weeks, these adhesions become more vascular and it is difficult to tackle these adhesions. So the first is more of conservative treatment, early surgery if there is strangulation. If surgery is required after 2 weeks, one has to be more cautious because these fibrinous adhesion become more vascular adhesions. Okay.
Okay, sir.
Now, you were before we end, just think of one condition where you were going for a non-operative management in case of a small bowel obstruction, and patient has a previous history of surgery, not an immediate post-operative period, but the patient has a previous history of surgery, suppose 2 years back. Now, this is as per your judgment, the patient is having a partial small bowel obstruction, right? Now, what do you want to do?
Sir, I will start conservative management, and in the simultaneously, I will do some imagings to rule out the cause of the obstruction. First, I will do, sir, X-ray of the abdomen in erect posture, and to confirm the diagnosis, I will go for CT scan of abdomen. And depending upon the imaging findings, I will plan the management.
When you decide the conservative treatment has failed,
Yes.
what is the time limit to say that patient is not responding, I should resort to surgery?
Just 72 hours.
24 hours.
So actually, when you are going to when you are going for a CT scan, actually, what is the best thing here? You are giving some water-soluble contrast medium, like gastrografin, right? So when you are giving gastrografin, you take another pill. You can take an X-ray even after 24 hours, not beyond that. If you see, the dye in the colon after 24 hours or within 24 hours, actually, these are the obstructions which are going to resolve. These are partial obstruction and probably going to resolve. So expected treatment further in these cases may be successful. But if it doesn't go, then you have to take care, or you have to decide this partial obstruction is probably not going to resolve by non-operative management. So this is something that we can take up in our practice more regularly.
So if the patient is improving, you can wait. If there is no improvement in 24 hours, one should take a decision for early exploration. So that is a dictum.
Yes,
Okay.
sir.
So I think
Yes, sir.
Dr. Patsu, you have covered the most of the things.
Yes,
So this is what is
that ideas
being
part
asked.
and the pseudo obstruction, these are left. And there are definitely few other situations like advanced malignancies where the patient present with intestinal obstruction. Those are very difficult situations actually to decide. And in many of the occasions, we land up in catastrophe after exploration. So other than that, the most common scenarios probably we have covered.
I can ask a uncommon question. You have some intraabdominal malignancy which can cause obstruction because of spread and this and that. Can you name 2 extraabdominal malignancy which can have obstruction? Xyluric. Got my point? Any extraabdominal
Yes, sir.
malignancy which can present with intestinal obstruction. 2 important extraabdominal malignancy. One is breast and another is melanoma. They can cause intraabdominal metastasis causing intestinal obstruction. These are all advanced disease. Okay.
Okay, sir.
Okay then. Any question from anybody? Any question? Anything in the chat box?
No, sir. There are no questions in the chat
Okay.
box.
Okay. Dr. Bosak like to say something? Dr. Bosak.
Yes, I'm hearing. This is a very good discussion. You have covered most of the points, and it is very good. It is a very, very informative discussion. Thank you.
That's it. Word down scenario. That's it.
Thank you. Thank you.
Okay. Thank you, Milind.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.